This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, my name is Gordon Smith. I'm a neuromuscular neurologist and chair of the Department of Neurology at Virginia Commonwealth University. And today I've got the great pleasure of speaking with Whitley Aamodt, who is an assistant professor of neurology at the University of Pennsylvania. She's authored a really interesting article for neurology that she's going to talk with us about today called End-of-Life Healthcare Service Use and Cost Among Medicare Decedents with Neurodegenerative Diseases. Whitley, thanks so much for joining me on the podcast today.
Thank you so much for having me.
I've really been looking forward to talking to you after reading this article. I found it really thought-provoking, and I guess I'm just curious how you became interested in this topic.
I've always been interested in exploring practical ways to improve patients' quality of life, which initially led to my interest in palliative care. Palliative care can really be implemented at any point in the disease course, but I'm most interested in studying care delivered during the end-of-life period, which I normally define as the last 6 months of life, which is a period that also corresponds with U.S. Medicare eligibility. End-of-life care is an extremely important topic that's often underexplored in patients with neurodegenerative diseases like Alzheimer's disease and Parkinson's disease, because it's difficult to study the topic, and I think it can make people feel very uncomfortable. But end-of-life care is very important and one of the few inevitabilities of life.
What I really enjoyed about this is, as I read the article, I realized how many preconceived notions I have about this topic that I hadn't really considered. And you're focusing on people who die from a neurodegenerative disease. And I wonder if we can maybe level set to talk about how common this is, right? For us, it's very common. But what percentage of deaths in the United States are due to a neurodegenerative disease?
In 2022, which is the most recent year of CDC data that's currently available, there were approximately 3.4 million deaths in the United States. Heart disease, cancer, and accidental injuries were the top 3 leading causes of death, followed by COVID-19, stroke, chronic lower respiratory diseases, and Alzheimer's disease, which was the 7th leading cause of death. If you sum the total number of stroke and Alzheimer's deaths, neurologic conditions are the 3rd leading cause of death in the U.S. But we all know that neurodegenerative diseases are slightly less common than stroke and likely contribute to about 5% of total deaths. These figures are based on U.S. death certificate data, which are notoriously unreliable. So I suspect this number is probably an underestimate, and we may not be capturing complications of these degenerative diseases that ultimately lead to a patient's death.
You just wonder how many patients who died for COVID had a progressive neurodegenerative disease that made that outcome more likely. So the approach you took was to look at healthcare utilization and decedents or among decedents who had Alzheimer's, Parkinson's, and ALS, and you compared it to pancreatic and brain cancer. I wonder if you could explain why you picked these specific disorders. It makes sense for the neurodegenerative disorders. Why pancreatic and brain cancer?
So I wanted to compare the most common neurodegenerative diseases to 2 different cancer types with higher mortality rates that are easier to identify in Medicare data. So malignant brain tumors and pancreatic cancer are just 2 examples of cancer with lower median survival rates and higher rates of palliative care and hospice referral, which I thought served as ideal comparison groups for more typical or appropriate, if you will, end-of-life care.
I already alluded to the fact that I found the results of this surprising and challenged my preconceived notions that I didn't know I had preconceived before reading your article. What were you expecting to find? And this is maybe an indirect way of saying what was your hypothesis, but what were you thinking the results were going to show you?
I initially hypothesized that individuals with a lower median survival rate, like persons with ALS and brain or pancreatic cancer, which are conditions that are considered more rapidly progressive diseases without a known cure, would receive lower intensity care at end of life than individuals with more prognostic uncertainty, like those with Parkinson's and Alzheimer's disease. And for the purposes of our study, lower intensity end of life care was defined as fewer emergency department visits, fewer hospitalizations, and the earlier initiation of hospice care, which we think is associated with improved quality of life and considered markers of better end of life care quality across most disease states.
I almost never do a podcast where I don't ask someone what were the results up front. My good friend Ted Burns always would say, give them the meat first. But I'm intentionally doing this a little opposite because that was my thought going in. And as someone who sees a lot of neuromuscular patients, I have this notion that we provide robust palliative care to patients with ALS. And while I don't work in an ALS clinic, I always tell them, look, we're going to do a good job of this. Now the reveal, what did you find?
So we found that there were a total of about 1.1 million Medicare Part A and B beneficiaries who died in 2018, of which about 358,000 people had a qualifying diagnosis. When we compared the demographic variables across our 5 comparison groups, we found that persons with neurodegenerative diseases were older and more frequently received Medicaid assistance than persons with either brain or pancreatic cancer. In all groups, healthcare service utilization increased over the last year of life, particularly in that last 6-month period, and total costs were predominantly attributed to inpatient care, which I don't think surprises anyone. In our adjusted regression models, we also found that persons with neurodegenerative diseases, as compared to persons with cancer, had greater odds of emergency department use, lower odds of hospitalization, and a lower odds of hospice enrollment. And then lastly, and one of our most interesting findings was when looking at outpatient primary and specialty care utilization, we found that primary care visits were very infrequent in the last year of life, and neurology visits were even less frequent among patients with neurodegenerative diseases. To give you a more specific example, only 1.5% of persons with Alzheimer's disease, 8.6% of persons with Parkinson's, and 32% of persons with ALS saw their neurologist in their last 6 months of life, which I think has really important care implications.
So maybe we can start there, because I'd like to, you gave us the 2 major areas of interesting and somewhat unexpected findings. Can you talk to us a little bit about what that implies, the relative infrequency of neurologist visits during the last 6 months of life? And to some extent, it makes sense when patients with ALS are nearing the end of their life, they're maybe not coming to a multidisciplinary clinic. I still was very surprised by those numbers. What are the implications of that finding?
Yeah, I think that's a great point. So most people assume that advanced care planning is best completed in the outpatient setting. But if we found that most patients with neurodegenerative conditions don't see their outpatient doctors in the end of life period, when should we really be having these conversations? And I think 3 scenarios come to my mind. First, I think we need to have these conversations much earlier in the disease course, possibly either at the time of diagnosis or in early to mid stages of disease, when patients can really participate in goals of care discussions, even if they make them uncomfortable. I think second, we need to have conversations in either emergency or inpatient settings if the majority of patients are seeking kind of acute care. And this means that non-neurology providers should feel comfortable in addressing these topics, or if not, feeling comfortable in kind of consulting inpatient neurologists or palliative care physicians to help. And third, I think we can do a better job of having these conversations in nursing homes. We didn't study nursing home residents in our data set, but I do wonder if some patients drop off from outpatient care because they're institutionalized. And if so, are nursing homes referring patients to hospice in a timely fashion? So I know based on my family's personal experience that the hospice referral was initiated by us rather than the facility itself.
Palliative care is incredibly important, and most of us will experience this firsthand, hopefully, at some point. Yet it doesn't feature prominently in training programs, and so many neurologists are just not well versed in this. Do you have thoughts about how we can address that gap?
I completely agree. I think data has shown that neurologists are often less comfortable with end-of-life care discussions than oncologists who receive more formal palliative care training. And so I really think that more emphasis should be placed on palliative care exposure in both neurology and residency and fellowship programs, particularly those who specialize in fields like cognitive neurology, movement disorders, neuromuscular medicine, where these end-of-life conversations might happen on a more frequent basis. I know when I was a neurology resident, palliative care was not a mandatory component of my training. I think that's fortunately changed across many programs nationwide, but there's still more work to be done.
And so the second aspect of this study that was particularly interesting was the difference in hospice enrollment and ED utilization between neurodegenerative disease and cancer. And that really surprised me. Kind of an overlapping explanation, I would imagine. But what do you think of those data, and what are the reasons for them?
So first, I think our data show that patients with neurodegenerative diseases do have acute care needs, even if they're not seeing their outpatient providers on a regular basis. And in our cohort, hospice enrollment was relatively high in the last 6 months of life across all groups. But when we controlled for specific sociodemographic and clinical variables, we found that persons with neurodegenerative diseases were significantly less likely to enroll in hospice than patients with cancer. So I initially thought these findings might be explained by prognostic uncertainty in neurological illnesses. But interestingly, persons with ALS, a condition with similar median survival to pancreatic cancer, also had a lower adjusted odds of referral, suggesting that there are other factors at play beyond neuroprognostication. And so there were 3 other reasons that came to my mind. So just like you mentioned first, I think neurologists might be less comfortable than oncologists initiating these end-of-life conversations with patients. Second, I think hospice enrollment is likely influenced by patient perceptions and preferences. In addition to maybe religious or cultural differences, I think more patients with Alzheimer's and Parkinson's disease have cognitive impairment than persons with cancer and may be unable to participate in care discussions, particularly later in the disease course. And then finally, hospice enrollment is undoubtedly influenced by resource availability and access. In addition to geographic differences in hospice resources, enrollment criteria differ between patients with neurologic conditions and those with cancer. And long term, we may need policy changes to ensure that more patients who qualify are actually appropriately enrolled in care in a timely fashion. I think this really suggests a need for clear pathways for palliative and hospice referral in the neurology literature.
Yeah, I was really surprised by these data for ALS patients in particular, given that most ALS providers are very comfortable having these conversations. And I'm just reflecting on it now. We talked a lot about translational neuroscience and back translation, taking something you've learned in a clinical trial or a human subject study and moving it into an animal model. And it seems to me you're back translating population data potentially into the clinical experience. I wonder if you've thought about going to the ALS clinic, and you've got a great one there, and talking to the patients to understand what their experiences have been. Obviously, pre-decedent patients.
Yes, we're actually conducting a study right now that's exploring patient preferences in Parkinson's disease towards end-of-life care planning. And I hope that we can extrapolate that to other disease processes, including ALS. In our study, we did find that ALS patients were younger than patients with Parkinson's and Alzheimer's, and I do wonder if age might be contributing to some of their care preferences, that they're just not ready to initiate these goals of care discussions.
Now, one question I had that I don't know that was directly addressed in the study, but you have the data, is that the effect of race and ethnicity. You controlled for this, but I wonder about healthcare disparities in this space. Did your data inform whether or not that's the case?
So this wasn't really a primary focus of the paper, but my short answer is yes to a certain degree. So our group actually conducted a prior study on end-of-life care and Medicare beneficiaries with Parkinson's. And in that study, we found that 62% of patients with Parkinson's are hospitalized in their last 6 months of life, which is quite a high number. And in that cohort, there were very notable sex and racial differences in care patterns. So male and non-white decedents with Parkinson's were more likely to be hospitalized at the end of life. And then once hospitalized, they were more likely to be admitted to the ICU or experience an in-hospital death, which is a marker of poor end-of-life care quality. So in the current study, we did find similar sex and racial differences that are not discussed in detail, but we do summarize them as supplemental tables 4 and 5.
We've talked about system-level solutions and policy. What advice do you have for our listeners individually about how they can ensure their patients receive the best end-of-life care?
I think the most important take-home message from the study is that we really need to do a better job of talking with our patients about their care preferences. Really, the earlier, the better. And I think this is especially true for persons with neurodegenerative conditions who might experience disease complications as their conditions progress. So these are not fun conversations to have either on a provider or a patient side. And they can also be very time-consuming during a routine clinical visit. So I think if resources allow, these conversations might deserve their own dedicated clinic visit or the assistance of an advanced practice provider or even a social worker if they're available in certain care settings. Also, I think when a provider suspects that a patient may be nearing the end of life, it's important to broach the topic of hospice as soon as possible because so many of our patients are either referred too late or just not at all. And if patients are not seeking outpatient care, neurohospitalists might be the providers that initiate these discussions when patients are hospitalized. In the end, I think our paper really supports the need for improved communication channels across all levels of care and disease states.
My experience has been that patients and their families are incredibly grateful for these conversations, as challenged as they are. So I know that may not be the thing we look to most in a day to have an end-of-life discussion, but patients really appreciate it and family appreciate it too. Has that been your experience?
Yes, very much so. Although it's difficult to initiate these conversations, I think if it's done in a very, respectful and compassionate way, I think people are very open to discussing end-of-life care. It applies to everyone regardless of their diagnosis or age.
Thank you so much. This has been a really fantastic discussion. I've enjoyed meeting you and learning about your research. I really encourage all of our listeners to check out your paper in the Green Journal. It's well worth the read, no matter what subspecialty you might practice or if you're a general neurologist. Again, the article is End-of-Life Healthcare Service Use and Cost Among Medicare Decedents with Neurodegenerative Disease. The topic is even more interesting than the title.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.